This year has been something that at our company, we've kind of coined 3 words: data, doctors, and leadership.
Healing is an art, medicine is a vocation, and healthcare is a business. And there are too many times physicians are on the wrong side of that equation. She got breathing treatment. She felt wonderful. We gave her the power to bring her kids to her mom's tomorrow so she can go and work her blue-collar job. That's a wonderful way that we help that young lady and her 3 children. So when you say doctors, data, leadership, I'm going to add one word to that, and that's P, and that's patience.
Well, welcome to another episode of the Leadership Lab. And today I'm excited about our discussion that we're going to have around healthcare finance and, more importantly, physician oversight in that space and how it integrates actually with the EMS system. I know a lot of the podcasts that I've been doing lately have been really focused around the integration of EMS delivery and in those models. And so I am excited. This week here in Austin, we're coming off of a fantastic conference, one of the world's largest EMS data companies called ESO. And so while here, I'm trying to loop in some fantastic, smart, the physician community as we begin to engage it through healthcare finance reform. So I'm excited to bring Dr. Cozzi onto my podcast. So welcome to the Leadership Lab, Dr.
Asbel, thank you for having me. It's a pleasure to be here. Austin has been great so far, so looking forward to having a conversation with you.
Perfect. And I can promise you that I'm going to try not to ask any questions that might be disruptive, but who am I kidding? I think it's really important. And when your name came across my desk from somebody that I highly admire, that was actually my inaugural podcast guest, was Dr. Eric Beck, as we talked about the $1 billion question. So if you are listening to this podcast today and you've not listened to that, I would strongly suggest you go back to that podcast. It's the very first one we ever did. And he really began to bring this conversation that we've been talking about for many years now. And I know that your paths have crossed because he's the one that talked to me and said, you've got to talk to Dr. Cozzi. And I am ecstatic that I was able to meet you last week through the process. So as we know, I kind of give an outline. So of course, we're not going to just get on this podcast. We do know what we're going to talk about, but we're going to organically talk about that. So why don't you, for people that might be hearing your name for the first time, tell us a little bit about yourself. Your bio is pretty fantastic, but I want it to come from you. Brag about yourself and what you've done in the EMS community, as well as the healthcare physician community, and how you're integrating it. And we're going to dive into the healthcare finance function side of it and from the physician's perspective.
Excellent. Well, thank you for allowing me to be here. Nick Cozzi. I'm an emergency physician and an EMS Medical Director. I grew up on the south side of Chicago, blue collar. My father was a firefighter. My mom was a medical biller, working hard every day, 2 parents, jobs, coming home after school and just trying to become something. And growing up, people told me I couldn't be a physician, so that drove me to want to become a physician even more. And I never took no for an answer. If the door was shut, I found a fence and I climbed over. If I couldn't climb the fence, I found a different way through. And I've been tenacious and very persistent throughout my early career in different areas. Ultimately went to college at the University of Wisconsin. Did not get into medical school the first time. I had a lot of rejections, but again, persisted, overcame that adversity, and ultimately got my MBA. I worked for the U.S. Secret Service, and then I transitioned back to medical school, finished, and then I went to residency. So I'm an emergency physician. Ultimately went to EMS fellowship at the fire department in New York City. And all of those things come together because of something, Asbel, you'll understand very well. Healing is an art, medicine is a vocation, and healthcare is a business. Yeah. And there are too many times physicians are on the wrong side of that equation, whether it's consolidation, markets penetrating, the role of non-government or money in our specialties. And ultimately, as a physician, I understand what the hospital is like at 3 o'clock in the morning because I see patients in the ER. But I also understand the finance side of healthcare economics, putting a much better alternative to what is happening right now in our healthcare system. So I'm in the city of Chicago. I have a lot of different opportunities. I work really hard. Like you, I wonder how often you sleep. Probably not a lot, but that's a little bit about me.
It's hard shutting your mind down. I will tell you, this year has been something that at our company, we've kind of coined 3 words: data, doctors, and leadership. And we've been talking about data now for a few years. This was introduced. This was a part of that first conversation that we had with Eric Beck, but this goes back to years ago, 10, 15, 20 years ago. We started talking about how do we disconnect care and EMS from transport? What does the data tell us? This was an epiphany that we had about 3 years ago when I was talking to some individuals in leadership at CSIA, which is a division of the Centers for Medicare and Medicaid Services. And we had the opportunity to talk to someone that had written some of the regulations around the High-Tech Act. And so I started asking questions like, what data company was there? Who was with EMS? And come to find out, there was really nobody that knew the EMS data set. And I remember picking up the phone and calling Eric and said, Eric, we got to get at the table. Because as they say, if you're not at the table, you're on the menu or somebody else is designing it for you. And so as we kind of work through this process, I just keep thinking, you know what? You've been advocating for payment policy. There's things that we've been doing, and nothing really seems to be moving. We hear it. We go to offices, we talk to leadership, and we anecdotally hear things. And now we got data across the line. So CMS has done all this great data from the EMS industry. Of course, there's always holes in everything when you do data, but it's the first comprehensive data set that we have. And so I'm going back looking at this, Dr. Cozzi, and saying, where are the doctors? Maybe we need to be talking through this process. And so let's talk about that. What's the physician's perspective of when they look at the data, what your standpoint is? Say before you got started in this, because you have probably a relevant knowledge that maybe many don't. They just are concentrating on the clinical care that they're giving, but you begin to marry the two. Can you talk to me a little bit about what you're doing?
It's an important correlation because when you said, where are the doctors? I was going to quickly respond, in the hospital seeing the patients, because that's where they are. They're doing good work.
Yeah.
They're treating and trying to take care of people on the worst days of their lives. But we have to have more physicians out in front, focusing on the reimbursement, focusing on long-term sustainability. Otherwise, we're not going to have financial viability. And I think it's much more built into physicians that money is a bad thing. Because when we were going through initial training and going into medical school, it was never something we could talk about. Don't talk about the money. Talk about why we're doing this, the service. And ultimately, when you get into residency and you're looking at jobs, money is a very hush-hush thing. Your salary, where you're going, and it's almost like a bad word. And we have to change that culture and that paradigm because physicians need to be able to talk about money in a healthy way. They have to talk about being reimbursed and compensated fairly for the work that they're doing to put food on their table. And so ultimately, I became more passionate about this as an MBA in my residency, post-residency, and doing the American College of Emergency Physician Reimbursement Leadership Development Program. It was 18 months. You learn the alphabet of emergency medicine reimbursement, but also the challenges and opportunities that we've had, whether it's through the government, through CMS, ultimately from chart to check. Dr. Jamie Shoemaker, one of my friends and colleagues in emergency medicine, we often talk about that around the country, from chart to check, exactly what happens from the bedside to actually getting reimbursed and why we're under so many headwinds right now. But that's where it comes from. And that's what physicians are doing. They're seeing patients. But we have to also get outside the hospital to advocate forcefully and vigorously for the areas for our financial lives.
So it's an interesting thing that you're talking about, like it's kind of hush hush or whatever. And it just the thought came to mind that the Catholic Charities mantra is no margin, no mission. And I think we need to have a practical talk about money in healthcare, because the reason why we have the healthcare system that we have here in the United States is because we do focus on that there needs to be a margin for reinvestment into new technologies or what have you. I think it gets down to what the appropriateness of the margin is. And that's the discussion that I think we need to have with physicians who are saying, I'm not following the same talking points. Because I remember having a conversation with Senate Finance leadership. This was several years ago. This was before COVID. And I remember asking them, what is an acceptable margin in healthcare? I asked somebody on the Democrat side, and I asked somebody on the Republican side, and they came up with the same number.
What was the number?
6 to 8%. 6 to 8% is what they thought the appropriate margin is. And I've had people, when I go and talk to people, other healthcare, they look at me, 6 to 8%, what do you mean? But that's kind of what we're talking about. And I think we have to have a practical reality, what the debate is on an acceptable margin. So what is fair?
Mm-hmm.
What's a fair reimbursement? You brought that up. What's fair? Fair is a subjective word. Fair to me is going to be different than what maybe you think fair, or the legislator that you're talking to. And I think this is why it's really important for the physicians to begin to insert themselves in a much more vocal way in understanding the clinical side. And how do we marry this to the finance side? And we can do it in a measurable way. I would rather be using words like measurable, because guess what measurable begins to tell me? I'm going to use data to measure. Mm-hmm. When I say fair, I'm using subjective words at that point in time. And that means what's fair to you may not be fair to me. But is there a way to measure fair? Is there a way to measure something? And I know I feel like I'm talking philosophical right now, but I think it needs to be a conversation that needs to be had that others are having. And so I'm excited about what you're doing in that piece of it. So I'd like to understand, as you dived in, you started with this in the master side. Mm-hmm. You started to look at it from a hospital. Tell me about the intersection with EMS, because you do a lot in the EMS space.
Sure.
As well. So talk to me about what you're doing, how you're looking at that, what you can talk about. Maybe you're doing just the stuff that you can talk about.
Sure, I appreciate that. I think in healthcare, we look at the EMS as a distinct locked box as it relates to emergency medicine, professional billing, as it relates to reimbursement. We look at these as discrete items as compared to a healthcare continuum and a team approach that transitions from your residence or your home all the way to the emergency department, through the hospital, back to wherever you're being discharged. There has to be warm handoffs, but there also has to be understanding that the patient never fundamentally changed in the 5 minutes before they were in the hospital, while they were with EMS, to now they're in the emergency department. Though they may be under a different structure, taken care of by people with a different tax ID, the patient's risks to them, to their condition, have not fundamentally changed. So as an EMS physician, we are constantly in a system of transport or no reimbursement. And it's interesting, when we teach people where that came from and why EMS is under the Department of Transportation, we have to remember the historical underpinnings, because if we don't remember history, we're doomed to repeat it, but we're not also in a position to overcome it. So when we look at Department of Transportation, 1966, accidental death and disability, you were more likely to be saved in the jungles of Vietnam than you were on the streets of Detroit or Chicago, based on motor vehicle collisions. And when you look at that sobering fact, and that the money, the investment, the EMS Act that came in the 70s, providing infrastructure, communications, and overall financial funding, it's not hard to understand why it came out of transportation. But in today's day and age, in 2026, we have outgrown that. In only the sense of it's more than just a transport as the mechanism for payment. The Department of Transportation, a wonderful partner for EMS, but ultimately we have to decouple transportation as it relates to the payment for EMS services for the future of EMS.
So let's talk about that. So let's talk about disconnecting care from transport, because that has been something we've talked about. There have been things that we've talked about, for whether it's treatment in place, whether it's community paramedicine, mobile integrated health. I really don't want to get into the definition side of it, because I think there's some problems in some of that. Let's just talk about from that design. Right now, EMS is only generally paid in the Medicare program, federal programs. I know it's anecdotal, that other stuff, but let's just talk about generally how it's been done. It has to be coupled with the transport. And this was new. So let's talk about where your ideas are going. Like, here's how I believe this is the first step that we go
For sure.
to disconnecting care from transport.
Well, let me paint a picture for the audience here and make this real. The other night I'm working, it's 3:00 in the morning, I get a phone call. There was a patient having an acute asthma exacerbation in one of the cities that I work in. And they were calling me for medical direction to provide them on next steps. The patient has a history of severe asthma. They're on a bunch of different medications. They've been hospitalized many times in the past. They've had to be intubated, breathing tube a few times. But ultimately, the patient received 3 rounds of breathing treatments. So 3 separate breathing treatments. They received steroids, and they received a medication called magnesium. They were on seeing the EMS clinicians for about 55 minutes or an hour. And they were requesting the patient was to refuse to go to the hospital. I spoke to the patient, assessed that they had medical decision-making capacity, they understood the risks of not going to the hospital. We had a very substantiated conversation that was based on mutual respect. They understood where we were coming from, and ultimately they were able to stay in their home. $0. And that, by definition, if that was an emergency department patient, that's critical care. And those interactions are frequent as it relates to treatment that is occurring in place, that is not decoupled from transport. And ultimately, the EMS clinicians are not being compensated for that.
So what would that look like in that nature if that was in the ER and you said that was critical care? What does, for the audience listening and for EMS that's listening right now that may not understand the difference, can you marry the two together? What would that look like if they could bill for that?
So in emergency medicine, you have what's called E&M codes. And ultimately, the E&M code there would be 99291. And that'd be critical care, which is greater than 30 minutes, less than 75 minutes. And ultimately, that would be probably $400 to $500 of bill that would go to Medicare and ultimately be reimbursed. Commercial insurances are different depending on that, but that's money that is currently not available in the system that we have because there's no mechanism. But that treatment, if they came into the ED and I'm working on this and I see the same patient, I do the same interventions, 3 breathing treatments, steroids, and magnesium, they're going to get billed for critical care services. That I performed almost life-saving care for that patient in a moment of extremis for that patient.
So I want to kind of go off that because that's a great story, and this makes me, and this is kind of off kind of where, but I think I want to get the education out to the people that are listening to right now. So let's take this example that you just gave. You're a physician under the physician oversight, under that code and that E&M code that you're talking about. What would that look like in a world where it's the paramedic that's doing that, or it's something like that? What would be your idea around that? It doesn't have to be right. I just want to understand your concept thinking. Should the same reimbursement quality, because I hear people talk about that, well, that's a part if a physician is a part of it. But what if it's a physician extender or it's a paramedic who's not technically considered a physician extender? What would that thought be around it? And I know I'm putting you on the spot with that, but I just want to understand, like, because I think the industry needs to begin, as we decouple this, there could be some nuances around it. And so we need to be able to be pretty malleable in the way that we think through this concept.
For sure. When you look at mobile emergency medicine, the concept that treatment is beyond the 4 walls of the emergency department, that it's beyond the brick and mortar, that as an emergency physician, Eric Beck, myself, and so many others around the country have a skill set that allows us to care for people in an acute, unscheduled way. It's beyond a hospital infrastructure building. What I would look at, let's say we had that same patient having an acute asthma exacerbation. They're being treated. The paramedics call me, and I'm able to have a actual live video session with that patient to talk to them, and almost a telemedicine encounter. I'm evaluating their work of breathing. I notice that they're not breathing as heavy. They're not using any muscles around their abdomen and their thorax to push air up and down in their lungs. And I'm able to evaluate them That's using my training and skill set to understand that although I may disagree with their decision not to go to the hospital, I can respect their ability to make that decision. I am not just passively receiving the information and talking to the patient, but I'm further participating as a physician in that care plan, in that interaction with that patient. That's what we need to be looking at, and that's what we should be trying to be reimbursed for, as you mentioned, in a measurable way, because not every patient has to go to the emergency department, right? Ambulance bills right now, and depending on where you're in the country, when you look at medical debt being the leading cause of bankruptcy, a lot of times patients refuse, even if they think they need to go to the hospital. I can't afford the ambulance bill, the $2,200, $2,800, depending on where you are. If they had the ability to, I treated them on scene. Through me, the EMS clinicians, albuterol, Decadron for steroids, and magnesium, the patient was feeling better. That doesn't have to be a lost interaction. People don't have to walk away from that feeling like, well, the physician told me if I didn't go to the hospital, I was going to die. That doesn't have to be like that. I basically did a visit with them. I acutely took care of them. I did exactly what I would have done in the emergency department. Nothing different. So that's where initial thought would be, that we'd have to participate in that interaction further. And there are mechanisms and means for us to do that.
So let me ask a question. I'm going to pivot here because you're talking about some stuff that I really want to engage on from the physician perspective. I was talking to another physician who's outside of our space, has nothing to do with EMS. And he basically said, you've got to educate more of the clinicians, the individuals that are in the hospital. They still think ambulance just transfers patients between, but there's more that you can actually do through the process. From your physician's perspective, because you're in EMS, you work in the ED, you're the chief medical officer for a lot of games, and I mean, there's a lot of stuff that you do in this space. For those that are on the periphery that might not be as engaged as you are, when you're having conversations, you're at the bar talking to another physician, do they understand the capacity to what you're talking, or do you have to walk them through an educational piece that kind of makes them begin to marry to understand the importance that EMS brings to this continuum, so we can disconnect care from transport?
This episode is sponsored by Solutions Group Services, healthcare leaders' go-to source for maximizing reimbursement and inspiring innovation. At Solutions Group Services, our technology and consulting expertise help organizations recover millions in hidden revenue without disrupting their workflow. Through our flagship AI-powered tech product, Black Ink, we reveal the dollars stuck in insurance claims and give you the map to get them back. Because for healthcare leaders, they know leaving money on the table isn't an option for their organization. Learn more at solutionsgroup.com and discoverblackink.com.
It's a great question. On balance, there's still a fundamental misunderstanding of EMS. And there are places and there are things like Agenda 2050, looking at EMS as more than a transportation service, more than getting to the hospital, but more of what treatment in place could look like in meeting patients in different areas. You see a lot of mobile integrated health programs attempting and trying to do that. Sustainability is also important. But it goes to a larger point, Asbel, and we talked about this at the beginning, is that physicians have been so busy with 4 years of college, 4 years of medical school, 3 to 5 years to 7 years in residency, another 1 to 2 of fellowship, that through all of that time, we never taught physicians the business of healthcare. I'll give you an example.
So the entire stint, we've not taught them to understand the business of healthcare.
Did you know that business education or healthcare economics, your area of expertise, or the business of payments, reimbursement, coding, none of those things are required in your medical education?
Really?
Not required in medical school, not required in residency, not required in fellowship. So what you have is a very competent physician coming out of training that may be financially illiterate And I say that respectfully,
Yeah.
but when it comes to the business of healthcare, because what do we say at the beginning? Healing is an art, medicine is a vocation, and healthcare is a business. They're good on the first two, not necessarily the third one. I had a great physician come up to me, very well-trained, clinically excellent physician. And we were going through some of the things. They're relatively new. And they said, can we schedule some time together? I said, I'd be happy to. What's up? And she said, I don't know a lot about reimbursement. I was never taught that. My heart sank. We're teaching all these physicians how to be clinically sound, but we've given up the high ground on the hill and the battlefield of measurable reimbursement and fair reimbursement in our country. So when I was in emergency medicine residency, we did a national survey of every EM residency program around the country, and we found out that A, people are putting together like Scotch tape type approaches towards this issue, and B, there's a specific set of skills that are important for ER doctors to understand as it relates to business. And we attempted to fill that. We formed a program that completely online, asynchronous, called the Practice Essentials of Emergency Medicine. But it goes to your point, where are the doctors? They're trying to become excellent clinically. When healthcare and business education is not on the front of mind, we have had the approach that this is going to make them wholesome because they can understand from chart to check how they actually get paid, who's getting paid in our healthcare system, and in our country, how physicians need to be much more aggressive and much more vocal on the front lines.
I so want to ask a question, because part of just listening to this is an aha moment for me, is I almost wonder if the system was set up to intentionally do that. You don't have to opine on it. But knowing what I know about healthcare finance, how the system works back in the 70s, how it began to morph in, because we're a pretty new industry, but the 70s is really where, the hospital payment system came in, then that became the physician system through the process. We're seeing more and more physicians being bought by hospital or hospital-owned systems to focus on the clinical care. So theoretically, do they really want them involved in the business? And I'm going to do a shout out here to one of my great friends, Dr. Brugman, who's an orthopedic surgeon, who is pretty dynamic, really understanding the clinical care. He's still a practicing orthopedic surgeon, but he knows reimbursement. It's amazing what happens, and it's amazing the impact that he's having to understand. This is just one of many that I know. It's why I'm so passionate that in the EMS space, we have got to have EMS physicians such as yourself that understand the marriage of the economics. You couldn't have said it better. But I did not know that. I did not know that through your entire stint of this many years, if you want that training, you've got to go back for the training yourself, but it's not a part of your normal curriculum. Is that what we're hearing? Like,
correct.
Generally, if you get it, it's because I went and got my subsequent master's in healthcare finance because I wanted to do that, to do something else.
It's 100% correct. You have to go out on your own. You have to find the education. If you're lucky, you'll have a mentor who is can excel at the finances of this and who could teach you different ways, whether it's personal finance, the healthcare economics, how our system actually runs is not part of the core requirements to be a physician. It should be, every medical school should be mandated. Just like nutrition is now being added, you should be mandated to understand business education.
Okay. So I know I'm going to say some controversial stuff because I hear this in EMS a lot too, because whether some EMS entities like it or not, we are under the oversight of our medical directors. Okay. And that's based upon the varying different organizational types that are out there. Some medical directors are actively involved, and some, in my opinion, are just pencil whipping medical directors that sign off on things. Regardless of what it is, that's kind of the thing that we've had some frank conversations in the industry about. I'm on the exact side that the medical directors need to be very involved. I think the medical directors need to be very involved in the clinical perspective. This is the only way we're going to disconnect care. We've had lots of those of us that work on the Hill, things that happened even within the ET3 program, or that ET3, what I call 1.0 version. There was a reason why there was this clinical connection between treatment in place or treatment in the field with a connection via telehealth with a clinician, or you had to have someone on site if you had somebody running in an ambulance with you or intersecting, which in some jurisdictions they have. There was a reason for that. And you mentioned that earlier in this example that you talked about with this asthma, this chronic asthma thing, that maybe they could be outside the walls of that. Our industry has long advocated for there to be a disconnect even from that. And in some states, there has been some disconnection of that, where certain things could be done under the medical protocol. So if the doctor wrote the medical protocols to allow for it, you could or could not have a telehealth visit that were involved in it. And then in some states, they don't allow it at all. The doctor has to be involved. And that's kind of part of this disconnection piece of it as well. I know you probably have heard that in the industry as well. Is there anything that you can opine on as we continue to talk and we continue to cultivate some of this? Is there a happy medium, or is this really healthcare is local? You're going to have to navigate through that process of it. But from a clinical perspective, from your perspective as a physician, not mine, not anyone else or that's out there telling, can you provide some optics into that the industry really needs to consider as we continue to debate this?
I have comments, but I want to ask you a question first. You mentioned the differences between active medical directors and maybe some who are not so active, maybe in name only. What qualities separate them, in your opinion? I'm close to this, right, as an EMS physician, but as somebody who's not a physician, I'm curious. Take me from the trees to overall seeing the forest. What qualities separate?
So now I'm being the one interviewed.
This episode is sponsored by Insight Advisors, the trusted partner EMS leaders turn to for clarity, compliance, and confidence. With N-Control, our intelligent audit tool, you can turn data into action revealing hidden revenue, compliance gaps, and workflow inefficiencies before they impact performance. Built by EMS experts, it delivers the independent validation every agency needs to move forward with confidence. And if audit privilege is something you need, we've got that covered too. Even if you already have an audit tool in place, connect with us to understand the difference between your current audit program and the N-Control life of a claim audit. Because when every claim counts, trusted insight matters. Learn more at discoverinsight.com.
Here's where I will tell you, as I've gone through and looked at that, generally, the physician that's heavily involved, I see them focus really on what are the outcomes that are being driven that we could advocate for from a reimbursement perspective that make logical sense when you're talking to a payer or something locally. I can tell quickly that the physician can talk about it. In those systems where the physician's involved, they have signed off on the medical protocols, but generally it's because a paramedic did the protocol. And did they really read through all of them is where I get to, because then what happens is the payer that we're negotiating with or whatever is circumspect when they talk about it with their physician community, why the protocol is the way that it is. And that's kind of my first trigger saying, how involved was your physician with this protocol? When I start getting the pushback from the payer, because I'm not antagonistic against the payers. I don't think the payers are always wrong. Does that make sense? Like, I think sometimes what happens is we've caused it to ourselves because we did things like this. Mm-hmm. And so now there's a distrust, and those that are doing the thing the right way, they get bottlenecked into that area. So I know that's a long way of answering your question, but that's kind of the general premise that I'm looking at, is because I've engaged with the physician community on the payer side. And generally the ones where I don't see them suspect is when we're actually appealing something or whatever with it, is because you immediately know, it's like, what are we disputing this for? It hit an edit in the system. We were talking about this in the car on the way over here. It hit an edit in the system because they have some AI engine that they programmed for everything, and you immediately override it.
Sure.
But then it snags someone else, and it's like, why would you do this? No ER physician would do this protocol. That's when I realize, then I start asking questions of them. Now, I'm not going to disclose it, but we know it, and people that are listening to now are going to have aha thinking, That's why I usually go back and say, how often are you meeting with the medical director?
For sure.
Sometimes there's people that meet with him once a year or once a month
If
or
that.
once a quarter, if that. And very rarely it might be that, they come in. But we did some stuff around that to say, a medical director shouldn't be a licensed medical director for 75 ambulance providers.
It's a nuanced question,
Mhm.
and I want to bridge off something you said, and that's the active medical directors. EMS physicians have been relatively a less mature subspecialty in emergency medicine. We've had active board certification since the mid-2010s, and ultimately is the largest growing faction of emergency medicine if you choose to subspecialize. I believe you're going to continue to see the next generation of EMS physicians be more hungry, be more active, be more involved, and be more intentional at the bedside, in the ambulance, with the medics, with the EMTs, with fire, because we have to, and because that's the direction of the next generation EMS physician. Now, we have to couple that, though, with measurable, your word, reimbursement and pay for the EMS physician, because a lot of systems have it to where it's uncompensated time providing some of these essential services. Online medical direction, QA, QI, those essential parts of any good medical director responsibilities also have to be compensated. And I feel like as we talk about the healthcare finance and the economics of what we're doing, you said earlier, no margin, no mission. You have to be incentivized in a certain way to do some of those activities. But some of those things are intangible. I'll give you an example. I was working last week and I had a paramedic come up to me in the city in which I work. And it was about 2:00 in the morning. Usually all these things happen in the middle of the night. And he said, Doc, can I talk to you? I said, sure thing. Emergency department seems like it's burning down around me. There's thousands of people everywhere. I said, sure. What's up? He said, you wrote me a letter a couple months ago. And I looked at him like, I knew his name, but I didn't have a lot of personal knowledge of him as a person. But I recalled this letter. And his eyes started to well up. And he said, you guys have no idea what you did for me. One day he's at work. His chief comes to his firehouse, hands him a letter, and he thinks he's going to get disciplined, which tells me something about your question, that as medical directors, we have to be more involved, because a lot of times there's some agencies where the medical director always has this hair standing up on the back of your neck type of an approach, because you might not have had positive interactions. The times you may have interacted with them, maybe discipline or case reviews. So that's what he thought that was going to be in that envelope. He tears open the envelope, opens it up, and it's a letter of praise from my hospital, our stroke team, myself as the medical director of EMS at this hospital. Thank you for what you did. You took care of this patient. She was 67 years old. She presented with a large vessel occlusion on her left side, profound deficits. She's a mother. She's a grandmother. Her family loves her. Very active in the community. Because of your swift response, evaluation, management, and treatment and care, and bringing them over to our hospital, we ultimately provided her the life-saving treatment. She had a thrombectomy. They removed the clot. She had a few days in the hospital, and she's back at home in her active lifestyle. Thank you for the difference you made. What you did and what you do matters, with appreciation and gratitude. He told me his kids put that letter on their refrigerator.
Mm.
So Asbel, I thought I was in the business of outcomes, your term that you brought. I thought it was about these outcomes have to match, and it's the business of relationships and people. And money always, that will always follow that. But he walked away thankful. I walked away thinking I should be thanking him. And I felt profoundly grateful for this interaction where a little of appreciation, recognition, and encouragement went a tremendous way. Didn't cost me anything. Didn't have to be compensated on my line item as a medical director of, this is one of your core duties, you must do. That interaction is going to give me a lot more juice for a long time.
It's where I think leadership comes in. It's why you have to have data, doctors, and leadership. And it's compassionate care that you're talking about. So you create an experience that will always be memorialized, that there's no amount of money that you can provide to it. And we forget that. Sometimes we get just focused on data and doctors or data or whatever, and we forget about the experience and the leadership through the process. We talk about that the patient is in the middle, that it's all about the patient. But when we start talking about, I find it interesting that your story that you just gave was not about the money. It was not about the care. It was about the experience that the person received. And many times we've noted that, like even when you're talking about, I was on a podcast with Donnie Woodyard, who is he's another disruptor. He talks a lot about history. He's doing some great, I just really like some of the stuff that he's talking about right now. But he talked about that is many times the only thing that the patient sees from the EMS community is the bill.
Very true.
And that's their first impression of EMS. And that was probably a statement that hit me square between the eyes because he's right. What things are we providing to the patient of their experience? What is the experience that they're receiving? And I get it, we're busy. We have a workforce that's focused on how do we do that. And this is why it's important to disconnect the transport with the care because we may not do as many transports.
For sure.
I remember having the conversation about this. This was a few weeks ago. And I'm going to end here. I'm going to ask you a few last questions that I'm going to want you to kind of talk about if you can do stuff in there. But I want to bring this point up because it hit home as I'm talking. And I had a guy come up to me after the speech because I was talking about this. I was talking about Hero Guide, StoryBrand. If you've not understood StoryBrand, just Google it in, put it into Claude, Grok it, whatever. Talk about the StoryBrand concept of Hero Guide. How do we guide people through the process? And this is where I was saying maybe our industry and the reason why we've not been able to do the disconnection of care and transport is because we've been in the hero spot too much. We need to be guiding, and maybe the doctors need to be at the front talking about this. I had a gentleman come up to me afterwards, and he's going to be listening to this podcast because he just said, you know what, Asbel, I agree with almost everything you said. You did one thing today that I disagreed with. And I said, well, what was that? And he said, I don't believe the physician should lead this. And I said, well, tell me why. Why do you think that? And as we drove down into it, I think it was the experience that he had of dealing with the physician that maybe they saw him as not to their level. Maybe there was some reason why he did not believe physicians should lead it, but it didn't consciously make sense to me. But I try to understand why is that viewpoint there, because he's not the only one with that viewpoint. I've heard it. And I've heard him say, well, what happens is they just want to skim off of what we're already struggling, and the doctors just want more because they want to take the money. And I said, that is not the doctors that I've talked to. That's not you. That's why I'm glad you said this story. I was figuring out if I was actually going to give this example, because what you just said in your story was the compassionate care of the physicians that I talked to. But there has to be a way to measure, to make the system fair, because the system does not work if people do not work in the system. And that is what this administration's trying to figure out. This is what previous administrations have tried to work out. And I believe if the doctors could get at the table, and I had my aha moments today that I'm going to go down to understand now that if we're not teaching physicians the basic principles of economics, it's why we're here today. Because what happened is you have loaned your power to another individual that understands the power of economics. I'm not a clinician, but when somebody talks to me, I'm thinking, I'm not the right person to be at the table saying this. Like, that's kind of the realization I've come to. That's why I'm wanting the doctors, get at the table. That's kind of where I'm at that. Now, I know it's a controversial statement, so I interrupted you. Go ahead.
You said the word loan. We've loaned it. We've outsourced it. We've sold it.
You sold it.
It's time to buy it back. It's time to buy it back. Because what I didn't tell you about the first story about the young woman, 3 rounds of breathing treatments, steroids, magnesium, almost an hour on scene. The reason she wanted to go to the hospital was that she's a single mother and she has 3 children at home and no one to watch her kids. Why does that interaction have to end in a refusal, where she's refusing service? It's such a bad experience and a connotation, isn't it? We had a great experience. She got breathing treatment. She felt wonderful. We gave her the power to bring her kids to her mom's tomorrow so she can go and work her blue-collar job. That's a wonderful way that we help that young lady and her 3 children. And we have to increase that experience. Yes, at the end of that interaction, there should be some compensation as it relates to the EMS service for the life-saving care that they just did. But isn't that what we're doing? So when you say doctors' data leadership, I'm going to add one word to that, and it's P, and that's patience. Because it's always, at the end of the day, we have to walk in and talk about the patients with us. Otherwise, we fall into the trap that maybe that individual had, that doctors are greedy, they're skimming, because we're not talking about that medic taking care of that patient having a life-threatening stroke, or that young mother of 3 children, single mom, just trying to make it every day.
So you have just amended my user summit, because 2 years ago, we talked about through the eyes of the patient. And so through the eyes of the patient, data, doctor, leadership. That is I'm going to give you credit for that to remind me to never forget everything that we do is always through the eyes of the patient. And so I could talk about this subject for a while, because you have we are on the right track, and Dr. Brueggemann, if he's listening, is going to be ecstatic about what you just said. We need to take it back. That you didn't loan it. Thank you for correcting me on that. You did not loan it. We need to take it back. We gave it away, and y'all are taking it back, and we're seeing that happen. And there's this movement that's going on. So all my hospital friends, I love y'all, really. You're doing yeoman's work, doing some great work, but we've really got to have the physicians leading this narrative to fix healthcare in its present form. I think it's going to take a group of individuals, not on your own, but we need to get back to that doctor-patient relationship. And it's going to look a little bit different. You've got extenders, all this other kind of stuff. We're talking 50,000-foot view here right now, Dr. Cozzi. But ultimately, you guys have got to get and marry that economics to it. So if there are 2 things outside of disconnecting care from transport in the EMS, there's 2 things that Dr. Cozzi could do in the next year, and he had no barriers. And he could implement that to make it what would those 2 things be?
In the vein of reimbursement?
In the vein of reimbursement. I'm a reimbursement guy, so in the vein of reimbursement.
I would decouple transport from reimbursement.
Okay.
So that young lady who had a wonderful interaction, who we gave all those treatments to, the EMS agency should be compensated for that. Okay. And I believe that we have to be much more intentional as it relates to not only interfacility transport, but specifically the use of ambulances for transporting patients in a myriad of reasons, in a myriad of ways. Whether it's to hospitals, from hospitals, to subacute nursing facilities, that is prime for disruption and prime for the right people who are mission-driven, who understand value to transform that industry.
Okay. And what's one thing that keeps you up at night?
In a good way or a bad way?
I don't care. You tell me.
One thing that keeps me up at night. Perspective always drives performance. And not just performance in a work way, but also realizing that I have to care for myself and my family. Like you have to care for yourself, your wife, and your daughter. That these problems seem existential, but sometimes the most important thing we can do is just be present in the moment.
Love it. Love it. Well, thank you for joining the Leadership Lab. Stay tuned, because he's going to come on again, but I didn't want to talk about it this time because there's some stuff that he's diving into from the ER physician perspective to EMS. Is some good work that's starting to happen. And I know others are going to start debuting it. We've kind of got to tease into it. So I want to bring you back on here in the next few months when that's ready to kind of go, to get that out, that there's this whole technology and the use of AI and disparate systems beginning to marry certain things that we've never had access to before. You're on the front line of starting to do some of this, Dr. Cozzi, from a healthcare finance reimbursement side. I got a peek at it this morning, and it was amazing. Is there anything that we can kind of tease the audience before we let them go, to kind of just marry around what you're working on? Is there anything that you can share with the audience about what you're doing right now?
We talked about this at the beginning. that this is a continuum of care. But there's opportunities to look at the care that's provided in the pre-hospital space as a continuum of care as it relates to what happens in the emergency department. So we could put a pin in that one.
Yeah.
To be determined, to be continued, and I look forward to coming back.
Absolutely. Thank you for joining us here on the Leadership Lab.